honor to have you with us today.
Thank you.
And I'm sure this is going to be an awesome session. And this is going to be awesome because all of you can participate. Please make your questions and comments on the Q&A chat box. And if you feel like talking or making a live question in the end of the session, please click on raise your hand, and then we can allow you to open your camera and microphone in the end of the session and discuss and use this amazing opportunity to discuss with Meryl and Norman about single ventricle features on echocardiography. So please participate, please make your questions and your comments on the Q&A box. Follow us on social media, and all of these are stored on our Congenital Heart Academy YouTube channel. This is being transmitted live on YouTube now. We know that some of you are watching on YouTube with your teams, on your ward, on your ICU, on your echo session. So we are very happy to have all of you. Be welcome. And if you want, if you really like this session and you want to share with your team, you just can go on our YouTube channel, get the link and send to your team so they can enjoy this amazing talk that I'm sure it's going to be. We are going to have on Friday, Dr. Anderson on his last talk about single ventricle physiology, about univentricular physiology. He's going to talk about the straddling valves. And after that, he kindly is going to continue with us, and we are going to start some other anomalies. First of them is going to be anomalous venous drainage, systemic and pulmonary, and then after that we are going to talk again about isomerism. And Dr. Gill is making an amazing ICU series. We are very happy with this series. The first one was about TGA. We were supposed to talk about since birth through adulthood, but the discussion was so rich that we stayed 1.5 hours discussing only the pre-op features of the TGA baby, and this topic is going to be continued in some other date, but now on next week, next Thursday, on the 13th, not this one, the next one, we are going to have his talk about systematic approach to post-op care of neonatal infants with congenital heart defects. This is going to be an amazing talk. It is very relaxed. It's like a ICU round, so everybody can give opinion and give their different perspectives. He has all the time people invited to talk, not only him. It was a very good experience. I hope you all can enjoy on the 13th. And now with you, our dear Dr. Meryl Cohen, who had a birthday yesterday. Happy birthday again. God bless you. And she's going to talk to us about the echo features of single ventricles. Thank you very much, Meryl.
Thank you so much, Grace and Sasha, as always, for your generosity and for allowing me to do this. And I'm so happy to have Norman here, one of my heroes. Makes me a little nervous to have him here, actually, but that's okay. Good morning and afternoon and evening for all of you who are joining us. Thank you so much. I'm going to talk to you about echocardiography of single ventricle today. Because it's a big topic, I'm going to talk about the sort of the preoperative or neonatal findings of this disease and not the postoperative findings. Sorry about that. I don't have any conflicts. So when you talk about single ventricle, and you can look at this picture on the right-hand side of your screen, which gives you a sense of the segmental anatomy. And as with every form of congenital heart disease, the more complex it gets, the more you need the segmental anatomy to help you appreciate the variations of disease. And so when I think about single ventricle, I think about true single ventricle, and that's when you have one dominant ventricle with only one inlet or ventricular sinus. And in those cases, you can have double inlet, you can have two AV valves, so-called double inlet, you can have a common AV valve, you can have one patent and one atretic or absent valve. And often these patients have an outflow chamber. Again, it's a ventricle that has a semilunar valve attached to it, but not an inflow. You can also have functional single ventricle. A lot of our patients have this, where they have one dominant ventricle but they have two ventricular sinuses, but the other sinus is quite small. And again, you can have common AV valves, such as with unbalanced AV canal, or you can have one patent and one atretic or hypoplastic valve. And then you can have complex forms of congenital heart disease where we just cannot septate the heart. And so this is considered, again, functionally single ventricle, but not true single ventricle. And so you can see this with some forms of double outlet right ventricle with remote VSD or superior inferior ventricles. Then there are many examples of these, and I'm not going to talk about these today. With regard to the variants of single ventricle, again, we talk about the true single ventricle, the one that has only one sinus or inflow. And we see these in single left ventricle, single right ventricle, tricuspid atresia. And then there are a group of patients where it's very difficult for us to distinguish the ventricular morphology, and we call those mixed morphology. And then you can have the functional single ventricle. Again, these have a big and a small ventricle with both of them having inflows. And that includes hypoplastic left heart syndrome, pulmonary atresia with intact ventricular septum, unbalanced atrioventricular canal, and double outlet right ventricle with mitral atresia. So when I think about these lesions as a whole, I go through systematically, again, their segmental anatomy to help me determine the features that I need to know to help me determine what surgery they might need and to help guide their care. And so the first thing we start with is their venous anatomy. Often they will have abnormal systemic veins or abnormal pulmonary veins. Although the systemic veins become important in the second and third stages of palliation, they're not terribly important for the first stage, but pulmonary venous anomalies are quite important. We then have to identify the size of the atrial communication, which is important when one of the AV valves is either atretic or very hypoplastic. The atrioventricular connections, the atrioventricular valve morphology and size to help us determine if there's risk for valve regurgitation, the morphology of the dominant chamber, and then assessment of ventricular performance, of course, and looking for that smaller chamber. The ventriculo-arterial alignment, which can be quite variable, the ventricular outflow chamber, and when you have an outflow chamber, so one that has no inflow, what happens is the ventricular septal defect becomes the outflow tract. And so the size of that defect and the type of that defect become quite important in the determination of whether those patients are going to develop outflow tract obstruction or not. The great arteries and their relationship, the presence and degree of obstruction of one or both of the semilunar valves, and then distal obstruction. Are the branch pulmonary arteries of adequate size? This helps determine if they're going to be good candidates for Glenn and Fontan surgeries. And then arch obstruction can occur as well. Patent ductus arteriosus and whether the patient's ductal dependent or not. So those are some of the common features of every patient with single ventricle that we must go through in our checklist when we're trying to determine what their surgical strategies might be. And so in general terms, if a patient with single ventricle has pulmonary outflow obstruction, so if they have atresia of the pulmonary outflow or it's very severe pulmonary stenosis, they will need an additional source of pulmonary blood flow. And that can be an aorta to pulmonary artery shunt. In some cases, it can be a conduit from the ventricle to the pulmonary arteries. And in the last 7 to 10 years, we've started much more frequently doing PDA stents in these patients to avoid surgery. Now, occasionally, these patients have just enough pulmonary stenosis so that they may not need an initial surgery at all. And so that's a group of patients that we sometimes have to take several days to weeks to determine. If the patient has systemic outflow obstruction, then they will likely undergo a variation of the Norwood procedure with a BT shunt or an RV to PA conduit, or they can undergo the hybrid procedure. And then every once in a while, a patient with single ventricle will have both outflows unobstructed, and we cannot leave them this way because the physiology is essentially a large VSD. And ultimately, there'll be too much pulmonary blood flow. Initially, they'll go into heart failure, and then they may ultimately develop pulmonary vascular disease. So this is a group of patients who we want to limit pulmonary blood flow by placing a pulmonary artery band. And then all of these patients, depending on what variation they have, will have to have an assessment of their atrial septum to see if the atrial septal defect will need to be enlarged if one of the AV valves is small or atretic. So some general rules for surgery, as I alluded to earlier, the systemic venous anatomy, though terribly important for the second and third stages, is not so important for the first palliation, but pulmonary venous abnormalities are very important. So patients who have total anomalous pulmonary venous connection in the setting of single ventricle have a much higher risk of poor outcome compared to the group that does not. And in many cases, those veins will be obstructed, and these patients can be quite critically ill. And their total anomalous pulmonary venous connection back to the heart can be tricky to perform. The atrial septum I already talked about. And then the other very important feature is what the outflow chambers are. So the VSD, if there's no sinus to the ventricle, acts as the outflow chamber so that the dominant ventricle gets blood through the VSD to the outflow. And so the size and type of that VSD become important. And if the aorta turns out to be the vessel that's arising from the outlet chamber, then it's very common that these patients will have to have an aorta to pulmonary artery anastomosis, so-called DKS. True single ventricle, from an anatomic standpoint, the most common true single ventricle we see is a single left ventricle. You have a dominant ventricle with a diminutive opposing outlet chamber, which sits on the anterior portion of the dominant ventricle. And if it's sitting on the right shoulder, the ventricle is D-looped. And if it's sitting on the left shoulder, the ventricle is L-looped most commonly. You can see these in association with two AV valves, so-called double inlet left ventricle, with a common AV valve, or atresia of one of the AV valves. Single right ventricle is much less common, and sometimes it's very hard for us to identify by echocardiography an additional ventricle. You again can have two AV valves, double inlet right ventricle, or a common valve, or atresia, or one of the other. And then the great artery relationship can be quite variable. You can have normally related great arteries, you can have transposition of the great arteries, and you can even have double outlet. And in fact, many patients with single right ventricle have double outlet. From a physiology perspective, these patients have a common mixing chamber. Both atria are emptying into this dominant ventricle. And so often the aortic and pulmonary artery saturations are the same, but in some cases there is some streaming that occurs. And so these patients can have VSD physiology, or they can have transposition physiology if they have extreme forms of streaming. And again, the VSD is a major factor, and pulmonary outflow tract obstruction is more common than systemic, but you can have systemic outflow tract obstruction. And when you do, you'll often have arch obstruction, coarctation, or interruption of the aortic arch as well. So here's a path specimen of a patient with single left ventricle. In order to avoid confusion between you and the practitioners and the surgeon, instead of really trying to figure out if it's a tricuspid or a mitral valve, my suggestion is to call the valves a right AV valve and a left AV valve. That helps all of us identify the location of those valves. These patients almost always have an anterior outlet chamber, and the looping depends on that chamber as I just described. The VSD becomes the outflow tract with the outflow chamber. It can be rimmed entirely in muscle, and if it is, it can become smaller over time, particularly with volume unloading surgeries such as the Glenn procedure. And the great arteries, typically one of the great arteries will sit wedged between the two AV valves, just as you see in the normal heart, and the other will typically arise from the outflow chamber. So you most commonly see transposition of the great arteries in association with single left ventricle. And so here is an example of, we finally get to the echo pictures, and here's a subcostal frontal view. And what you see in this sweep is left atrium, right atrium. You see the common ventricle. You see 2 AV valves entering it. And as it comes around again, you'll see, again, 2 AV valves entering it. You see a vessel arising from that ventricle, which is the pulmonary artery. And then at the very end of the sweep, so there's the pulmonary artery. At the very end of the sweep, you start to see the outflow chamber, which is on the left side, and you see the aorta arising from it. In this particular case, the VSD is quite large, as you see in the subcostal sagittal view. So the aorta is large and there's no coarctation. The conal septum is directed a little bit towards the pulmonary artery. So this patient may ultimately develop some pulmonary stenosis, but both outflows are essentially unobstructed in this patient. And you can see in this apical 4-chamber view how both AV valves, which are both of good size, are entering the left ventricle. So in this case, trying to do an atrial septectomy is not terribly important because both AV valves are of good size. In contrast, here's another patient. So this is double inlet left ventricle with TGA with SDD. The other patient had SLL because the ventricle was looped to the left because the outflow chamber was on the left side. So this is the opposite of that. Probably about 2/3 of patients with double inlet left ventricle are L-looped and about 1/3 are D-looped. And so here again, you see the atrial septum. You start to see the single ventricle. And in this case, what you see is you'll see a great artery arising from the single ventricle as the sweep comes around again here. That's the pulmonary artery. And then if you look at this shortened clip, you see the aorta in this case is very, very small compared to the pulmonary artery. Pulmonary artery arising from the left ventricle, aorta arising from the right ventricle, which is on the right, D-looped. And look, the VSD is quite small in this patient. And so the aorta is also very small. And so this is a patient who will have to have a Norwood variation, a DKS. And what you also notice about this patient in the apical 4-chamber view in this color compares clip is that in this case, the right AV valve is much smaller than the left AV valve. And so this patient will also have to undergo an atrial septectomy. So very different variations of the same disease, but completely different surgical strategies for them. And this is a very rare example of double inlet left ventricle, so-called Holmes heart. This is one of the featured hearts on display in Maud Abbott's medical museum in Montreal. The Holmes heart is double inlet left ventricle with normally related great arteries and typically with pulmonary stenosis. And so what you see here is you see the right atrium, left atrium. You see the aorta arising from this left ventricle. You actually can see that there's continuity between the AV valve and the aorta in this patient here. And then you see an RV outflow chamber, which gives rise to the pulmonary artery. And the great arteries are crossing each other and normally related to each other. And there's pulmonary stenosis. And here on the right side of your screen, you see both AV valves sort of blinking at you with the RV outflow tract being small here. Single right ventricle is very rare. You can see it in association with heterotaxy syndrome, particularly with common AV canal. The ventricle will typically appear more trabeculated than in double inlet left ventricle or a single left ventricle. Often it's very hard for us to find an outlet chamber in these patients, but you can often see a hip pocket, a posterior left ventricle in about 20% of patients. Certainly on path specimens, it's often, again, very hard by echocardiography. One of the things that you have to distinguish single right ventricle from is patients who have a very large VSD. And I've seen this mistake been made in the past. And it's very easy to make this mistake because there's a posterior medial ridge of muscle between the AV valves that can appear to be a ventricular septum in these patients. And so some of these patients get misdiagnosed as having a very large VSD. And the clue is that there will be attachments of both AV valves to this ridge, which you should not see if it's a ventricular septum. And often, because you can't find that other ventricle, opposing ventricle, often these patients will have double outlet right ventricle. And it's a very tough diagnosis to make. You can see how in this apical four-chamber view with two AV valves, that you could convince yourself that this is a ventricular septum. Same here, this ridge here could look like a ventricular septum. And so it can be quite a tricky diagnosis, and it's pretty rare as well. Tricuspid atresia or absent or right AV connection. The most common is the muscular type where there's true absence of the connection, meaning that the right atrium is not connected to the right ventricle at all. You could put a pin through the right atrium, go outside the heart and go back into the right ventricle. And it's usually as a result of failure of the expansion of the canal towards the embryologic RV. So what becomes important in these patients, because there's no way for the blood to get out other than the atrial septal defect, is the size of that defect is very important. It's also important to recognize in trichotresia that patients, particularly who have transposition of the great arteries in association with it, are likely to have juxtaposition of the atrial appendages. So you want to actually make sure you identify if there's juxtaposition and not mistake that for the atrial communication. The size of the ventricular septal defect becomes important, again, because it becomes the outflow tract. Often these defects are muscular and they can get smaller over time. And the great artery relationship, most commonly you see normally related great arteries, but you can see transposition, and you can even occasionally see double outlet right ventricle from that small outlet chamber. And often one of the outflows is obstructed. So here's trichotresia with SDS with normally related great arteries. Subcostal LAO view, you see the aorta arising from the left ventricle. You start to see the ventricular septal defect here, which does not look terribly big. And you get at the very end, you get a sense that the pulmonary outflow is quite small. In this apical four-chamber view, you again see the very diminutive right ventricle. You see the aorta arising from the left ventricle with mitral to aortic continuity. You see the ventricular septal defect here. And at the very end of the clip, you see the right ventricular outflow tract and the pulmonary artery crossing over it, and only mildly hypoplastic in this case. It's also fairly common to see tricuspid atresia with transposition of the great arteries with the aorta to the right, so segments SDD. And again, the same subcostal sweep as in the previous example. You see the atrial septum here, right atrium, left atrium. You start to see the pulmonary artery arising from the left ventricle. And then at the end of the clip, you see the aorta coming from the right ventricle here. And you see that in this apical four-chamber view as well. So here is the mitral valve, the left ventricle, the pulmonary artery arising from the left ventricle. And at the very end of the clip, you see the aorta in parallel coming off the right ventricle. You see the ventricular septal defect is quite small in this patient, and the aorta is small. And so this patient is likely to require a variant of the Norwood procedure as their first palliation. Hypoplastic left heart syndrome is something we see very, very commonly. There are multiple subtypes, which I'll go over with you in a moment. And of course, the atrial septal anatomy becomes quite critical in this disease, not only in need of the Norwood procedure, but now that the hybrid procedure is often performed, we want to be sure that the atrial communication is not going to get smaller over time. Because if that communication gets smaller, the patient develops pulmonary venous hypertension, ultimately pulmonary arterial hypertension, and no longer is a candidate for going down the single ventricle palliation pathway. Tricuspid valve function is important, RV function, pulmonary valve function, the PDA size preoperatively, and of course the size of the ascending aorta, the surgeon often wants to know because they're going to have to anastomose that to the pulmonary artery. The most common subtype of HLHS is aortic atresia, mitral atresia. The LV is often quite diminutive in this disorder, and it often depends on when the atresia occurs. So if it occurs early, you may see almost no LV at all. If the atresia occurs later, the LV may be a little bit larger in size. Going along with that, the ascending aorta is often very, very small and may be only the size of a coronary artery. And of course, because there's mitral atresia, it's essential that there be an adequate atrial communication in this group of patients. And here are some examples of that. Here you can see left atrium, right atrium in this patient, very small left atrium, a tiny little left ventricle. And then you can just make out the very, very tiny at the end of the sweep aorta here compared to the very large pulmonary artery. In this apical four-chamber view, you can see how tiny the left ventricle is compared to the right ventricle. It's almost non-existent. Here's the left atrium and right atrium. And sometimes the ascending aorta can be 1 millimeter or 1.5 millimeters, same size as a coronary artery. Transverse arch being usually much larger because the flow is coming through the patent ductus arteriosus. Aortic hypoplasia, mitral hypoplasia, you'll often have antegrade flow across both the aortic and the mitral valves. And there is a huge spectrum and severity of the LV hypoplasia and often depends on the size of the mitral valve. In borderline cases, a two-ventricle repair may be attempted or considered. And in these cases, even if you do single ventricle palliation, the LV often squeezes and so may help augment cardiac output. The aortic atresia mitral hypoplasia subtype, again, LV size is variable. And the LV in these cases, however, is often very poorly contractile because flow is able to get into the ventricle, but it really can't get out. You'll see, as in this path specimen, you can have endocardial fibroelastosis. Mitral regurgitation may become an important factor in these patients. And in fact, there's a subset of very high-risk patients who have mitral hypoplasia, aortic atresia with severe mitral regurgitation and intact atrial septum. And often those LVs are quite large, but completely don't work. And that's a very high-risk group of patients. In the long term, this group can develop clots in their left ventricle. So because flow can get in and it really can't get out. And they are at risk for, of course, coronary cameral fistulae. If the blood is able to get in and it can't get out, it has to go somewhere. And so abnormal fistulous connections develop between the left ventricle and the coronary arteries, similar to what we see in pulmonary atresia with intact ventricular septum. And so here are just some examples of coronary fistulae that you see in both the path specimens and in both of these echo examples. And in some studies, this is a high-risk group for sudden death, although this has not borne out in the SVR trial. Some consider other surgical options when they see significant coronary cameral fistulae in this population of patients and may send these patients down the transplant route instead of the single ventricle palliation route. And then finally, the most unusual form of HLHS is aortic hypoplasia with mitral atresia. And you might say, how can that happen? And that's because it's always associated with a ventricular septal defect. So the patient has mitral atresia, but flow is able to get into the left ventricle and out the aorta by way of a VSD. And so the LV and aortic size may be variable, and they are dependent on the size of the VSD, just as we saw for tricuspid atresia and double inlet ventricle. The aorta often may be close to normal size, as you see in this example. As you see this clip sweep, you see the aorta is actually quite large because of this large ventricular septal defect, even though there's mitral atresia. Because there's mitral atresia, you still need to address the atrial septum in this group of patients. And then there are other variants of HLHS, double outlet right ventricle with mitral atresia, which we went over in our DORV talk a number of weeks ago. So these patients have mitral atresia, but both outflows arise from the right ventricle, as you can see in this path specimen. And then, of course, unbalanced AV canal defect with all of the flow directed towards one ventricle. Pulmonary atresia also is quite variable, similar to HLHS. You can have variable hypoplasia of the right ventricle and the tricuspid valve. About 70 to 80% of these patients will have a developed infundibulum, which is the cone of muscle underneath the pulmonary valve. The main pulmonary artery is often present, and the branch pulmonary arteries are usually well developed. And this is in contrast to patients with severe forms of tetralogy of Fallot with pulmonary atresia. He'll often see a tortuous patent ductus arteriosus, and this may become important in the consideration of a PDA stent. And then there's a subset of these patients in whom the RV is actually quite dilated. And we see this in the setting of severe tricuspid regurgitation. So patients who have tricuspid valve dysplasia or Epstein anomaly. And so the important features by echo that we need to know about, again, atrial septum, because it is going to be hard for that blood to get into the right ventricle. It must go across the atrial septum in an unobstructed fashion from the right atrium to the left atrium. We assess for the presence of an infundibulum. And one of the most important features of this disorder is measuring accurately the size of the tricuspid valve. Often the secondary inflow is much narrower than the actual annulus because the right ventricle is very hypertrophied. So it's hypoplastic and hypertrophied at the same time. And measurement of this valve helps us determine the feasibility of a two-ventricle repair. It's very important to assess for the presence and severity of tricuspid regurgitation. And if present, measure the RV pressure estimate, the size of the PDA and its insertion. And then, as I just alluded to with hypoplastic left heart syndrome, these patients are at risk for coronary fistulae as well. And so here is an RAO view, a subcostal RAO view in the same orientation as this path specimen, where you see this patient has a very well-developed infundibulum. The RV is very hypertrophied. The tricuspid valve is hypoplastic. The main pulmonary artery is well-developed. In fact, the pulmonary valve leaflets are there, they're just fused. And so this is a patient whom you might consider doing radiofrequency opening of the pulmonary valve and a pulmonary valve dilation. And this patient may be able to have ultimately a two-ventricle repair. There's tremendous variation, tricuspid and right ventricular size, and generally the RV size is dictated by the tricuspid valve size. So here you see a very hypoplastic right ventricle with a tiny tricuspid valve. In contrast, here you see a somewhat larger tricuspid valve and larger right ventricle with a lot of hypertrophy at the apex of the right ventricle. And just a fairly common rule of thumb in this group of patients is that if you have pulmonary atresia with intact septum and no tricuspid regurgitation, you should worry that this patient has coronary fistulae. Again, the blood is going into the ventricle, it has to have a way to get out. And so if it can't go back through the tricuspid valve, these patients can develop fistulous connections. If the patient has tricuspid regurgitation, it's less likely that they will have coronary fistulae. It doesn't mean they can't have them, but it's just less likely. The flow must go somewhere. If there's no TR, the inflow egresses by way of these sinusoid connections with the coronary arteries. And here's the apical four-chamber view where you see a very diminutive tricuspid valve and inflow into this right ventricle. You have to bring your scale way down often to see this inflow. And what you see is this patient has no tricuspid regurgitation, and therefore you'd be concerned this patient has coronary fistulae. In contrast, this patient, oops, sorry about that. I don't think it's going to let me do it. Hopefully it will. Nope. Sorry, but that one had tricuspid regurgitation, and so was less likely to have coronary fistulae. Here you can identify often, again, bringing your scale down, your color scale down, that these patients will have coronary cameral fistulae. Now, though we can identify these by echocardiography, we are not able to tell if these coronary fistulae are RV dependent or complicated. And importantly, we cannot tell if you decompress the right ventricle in an attempt to do a 2-ventricle repair if you'll develop coronary ischemia in these patients. And so these patients must undergo another modality to make that determination, which is most commonly cardiac catheterization. So this is one of the rare forms of single ventricle that before going for surgical repair require cardiac catheterization to make that assessment. Just briefly, I'll touch upon some other issues for single ventricle. I mentioned systemic venous abnormalities. Often these patients will have bilateral superior vena cava, as you see here, with no bridging vein. Again, this is not terribly important in the first stage, but will be important when you're considering the second and third stages. Here is an example of a patient with a very large coronary sinus because there's interruption of the inferior vena cava to the left superior vena cava, so the coronary sinus is gigantic in this patient. I mentioned that pulmonary venous abnormalities are quite important for the first procedure, and total anomalous pulmonary venous connection heralds a very bad prognosis for single ventricle in pretty much any study you look at, even most recent studies. And here's an example of total anomalous pulmonary venous connection infradiaphragmatic. You can see the vertical vein going down towards the diaphragm, and this sort of upside down Christmas tree orientation of the pulmonary veins as they make their way into the vertical vein. And then I keep harping on the atrial septum, which is very important when one of the AV valves is hypoplastic or atretic. And here's an example in HLHS. You can see that even though the left atrium in this patient is small, you can see that it looks quite distended, and actually the pulmonary veins look distended as well. And so these are under high pressure, and you can see this high velocity jet getting from the left atrium to the right atrium. So these patients often have LA hypertension, which reflects back to their pulmonary veins, and they get pulmonary venous hypertension. And in addition to just looking for atrial septal restriction, it's also important to know the anatomy. Many of the patients, commonly with HLHS, will have a deviated septum primum or primary septum. So here is the septum primum, and instead of being attached to the septum secundum here, it's deviated towards the left atrium and is attached to the left atrial wall. And you can see that nicely, that curvature nicely in this still frame image. And this is important because if you're considering, first of all, sometimes you can see the right pulmonary veins on the right side of this deviation, and the surgeon can be fooled into thinking that the atrial septum is wide open when it's not. And the other reason it's important is in patients who are undergoing the hybrid procedure, this type of atrial anatomy can become restrictive over time, and often these patients will need a stent later on. So in conclusion, single ventricle comes in many sizes and shapes and variations, and the anatomy really dictates the surgical strategy. And a systemic approach by echocardiography to these lesions leads to accurate diagnosis, prediction of the physiology, and helps in the decision-making for initial palliation. And then beyond that, serial assessment is needed for the development of complications, such as AV valve function looking for regurgitation, whether the atrial septum is becoming restrictive, if pulmonary venous abnormalities or stenosis is developing, and of course, the ventricular septal defect, if it is the outflow, whether it's becoming restrictive over time. And this, again, helps us dictate whether further surgery or intervention is required. Thank you so much for your time.
Thanks, Meryl. I think that that's amazing. That's really comprehensive, you know, and re-epilogative exposure about this single ventricle. And I hope that, because we have people from all around the world, and I'm sure the message is coming, and I'm sure that Norman can add something. I don't know if
he always can.
Yeah.
Always.
Well, I'm unmuted, so
There you
first
are.
thing I should say, Meryl, is that was brilliant. I think we've used the word amazing a little bit too frequently in these meetings. But what was really remarkable was that in a matter of 45 minutes or less on my watch, you managed to cover the entire spectrum of the diseases in a way which was so clear and illuminating that I'm actually really amazed that you could do this, because all the members of the Congenital Heart Academy that are listening this morning have listened to Bob Anderson talking for 5 weeks on different aspects of univentricular atrioventricular connections. And it obviously is a very complicated subject. And it's a subject that I think that is totally important. The issue today, of course, is that hyperplastic left heart syndrome is probably the most important form of single ventricle physiology that we have to deal with. And I think that you covered that very beautifully. I'm just quite overwhelmed by the fact that you were able to do this in such a short time. And it was really very beautifully articulated. The slides were all beautiful. And I am writing a chapter in my volume on this at the moment. And I also have Diane Spicer's amazing pictures. Yeah. I mean, really, she's one of the great resources that we have in cardiology today. And her pictures are absolutely exquisite. I've been in her laboratory where it is a little closet which contains thousands of specimens packed one up against the other. And she really has done an absolutely amazing job in carrying on the work of Bob Van Meerop at the University of Florida in Gainesville. So I have nothing else to say that you did a complete job on this. You could have, I'm sorry that you didn't take the extra 15 minutes to tell us more about this, but it was absolutely wonderful, and thank you very much.
Thanks. Thank you so much, Norman.
Amazing talk, Meryl, really.
We could go on and on. I think what I was trying to relay is just the variations of disease. I mean, I think in each patient, what I was trying to emphasize is that with each variation of disease, you have to think in your mind how the blood is flowing, where it can be obstructed, and that will help you determine what surgical strategy needs to be done. It's really not that complicated. I think people get overwhelmed by it, but actually if you just go it in that systematic way, this is how I teach my fellows to do it, then you're able to really, help the surgeon understand what the steps are and even predict. When I see an atrial septum that's unobstructed right now, but has a deviated septum primum, for example, I know that that's going to be obstructed. Even if it's not obstructed today, it will be ultimately. And so those patients are going to need something done about that. If we see that if we see that the VSD in an outflow chamber is rimmed by muscle, then I'm always very concerned that that outflow will become obstructed over time and will ultimately need to have often, if the aorta is arising from it, for example, a DKS. And so we go through this strategy with each patient, and if you're able to do that, then you can, not always, but usually make the right decisions about the stage palliation that they require.
Totally agree. And you covered all of that in a very elegant way. Thank you very much for that. We have a lot of questions on our Q&A chat box. And I'm going to start with one from my fellow here from Qatar, Yahya. And he's asking something that is very interesting. We are talking about to help the surgeons to assess the best strategy. And he's making a question about when we have a single ventricle physiology. If we have totally anomalous venous return, but non-obstructive. Yeah. Do we need to prepare it before, or we can wait until the gland if they are supracardiac?
That is the $1 million question. I think that is an excellent question. And often I think that we don't know the answer to it. I think some surgeons feel comfortable leaving that pathway alone if it's unobstructed and dealing with it at the Glen. Others feel that they want to repair it right away. And I think, you know, it really depends, because sometimes those anomalous connections can become obstructed over time. So even if they're not obstructed to begin with, they can become obstructed later. So it tends to be a call, I think, of the surgeon for the most part. I don't know what you think, Sasha. I would, you know.
No, I think that because I am not such a huge experience, but we prefer to unobstruct on before just to doesn't have a surprise on the way. So
meaning you do it at the first operation?
Yes.
Yeah. Yeah.
Yes, because then you have already prepared for Glen.
Yes, and, right.
Post-operative care of some patient with obstructed total anomalies, it's very amazing for the intensivist. So
it's not amazing, we hate it.
I think that the question was because of post-operative care, not for a diagnostic tool.
Yeah, yeah.
I think that is a big impact on post-operative care of this case.
For sure, for sure. And we have one echocardiographic question from Mohammed Al-Beftar. I don't know where he's from, but he's saying, how do you comment on your echo report, the single ventricle size and function? Any measurement? How do you assess that?
So that's, you know, that could be a whole other talk, is how you assess function in these patients. And I sort of geared this talk towards anatomy. Single ventricle.
Next talk.
Single ventricle function is a very tricky business. The truth of it is we don't have a perfect way of measuring function in this group of patients. I've been doing this over 25 years, Norman even longer, and I still don't think we have the perfect way of assessing function in the single ventricle patients. We certainly have new tools available to us, which are helpful. And I think ultimately, honestly, I think ultimately artificial intelligence will be the way that we are able to make this assessment as accurate as possible. 3D ejection fraction, I think, will ultimately become the way that we do this, just like we use, you know, we consider MRI sort of the gold standard in these patients. And certainly all of our patients who are going through their Glen and Fontan ultimately get an MRI. And we really invest a lot of our belief in the MRI ejection fraction. I think we can get to that point with echocardiography. Some of the other tools, which are subtler, will, I think, be helpful, such as strain and strain rate and various other tools and fractional area change. There's multiple things you can do, TAPSI. But I'm not sure the S to D ratio that Norman developed. Many of these are terrific, but often require certain things, like the S to D ratio requires AV valve regurgitation, for example. So I think ultimately we'll get there with 3D EF, but I just don't think we're there yet. Norman, what are your thoughts on this?
Well, I would echo exactly what you said. The thing about the SD ratio, though, if I could just add a little thing, is you don't really need to use AV valve regurg to do it. You can use AV valve motion. And of course, the period in which the valve is open in diastole is really quite critical. So if you take the cardiac cycle and you take the period that's open in diastole and subtract it, you have the SD ratio right there. So you really only need an RR interval and a measurement of valve opening to get an SD ratio. Again, that's I think I'd say that there are thousands of tests that you can do to get the function, and this is a very difficult issue, even in terms of MRI. I think we can get some kind of a good idea of how the ventricle is functioning just by looking at it. And I know that that is an area that is quite critical, because subjective assessment is not very good. But I think if somebody like you or I, who have worked in the field of single ventricles for a long time, we can know with some degree of accuracy whether the ventricle is functioning well or functioning poorly. The problem is not whether it's really functioning poorly or really functioning well, but the area in between where we are seeing the fall off of ventricular function that becomes the issue that we really need to look at.
Absolutely. Totally agree.
Now, I want to tell you something I want to ask to both. This type of ventricle is very challenging for surgeon for all the postoperative care. And I'm sure the worst moment is when you add a BT shunt to this ventricle. Because as Norman said, you can try to prevent ventricular dysfunction before do a BT shunt. But I think, and we saw sometimes, when this ventricle suffer dramatically, and you don't know which sides of shunt you put small, and then the saturation come. You put big, then right or ventricular failure come. Do you have some, in your experience, rather than, of course, on echo, some, tips and tricks, or have matured some idea how you can predict, at least, because we are for us, it's very easy to make a patient desaturated. We put a small BT shunt, there'll be good function, but low saturation, and they suffer ischemia from the ventricle. So, this is another 1-2 million question, but if you have some, advice, some suggestion for us.
Yeah, I think it's really tricky. As you say, if the shunt's too small, you're blue. If the shunt's too big, you're in heart failure. Let's just be honest about what we're doing here. We're trying to create something that's not meant to be created. And in doing that, we use strategies that are available to us, and those options are quite limited. If you do a BT shunt, then your QP to QS is often more than 1-to-1, so you have a volume loaded ventricle. It can result in AV valve regurgitation, dysfunction, etc. But if you do RV to PA conduits, now you've put a hole in the one ventricle you have. And we have seen, later on, dysfunction of that portion of the ventricle. Sometimes you put it too close to the semilunar valve, and you can cause dysfunction of the one semilunar valve they have. I think it's very tricky to know. And even with the hybrid, say if you're going to just not even do the surgery and do a hybrid, pulmonary artery banding is very tricky business. Getting it right, putting two bands on two different pulmonary arteries, which are of different sizes, and getting them exactly right so that they both have just enough pulmonary blood flow, but not too much, is another very challenging thing. So I don't think there's any magic bullet here. And what you need is, honestly, prenatal diagnosis. So the things you can control. So prenatal diagnosis means that the patient will not present in extremis, and so that you'll have a patient with, essentially a good preoperative course, who potentially doesn't need to be on a ventilator and is doing okay before the surgery for the first few days of life. You need good postoperative care after the procedure. And that means, sort of no rhythm problems, eventually not being on pressors, trying to get off the ventilator, all the tests that we use. And so all of those things sort of, accrue together to determine what the outcome's going to be, honestly, when the patient's 25 or 30 years old.
Thank you. Norman.
Well, there's very little that I can say that would help here. I mean, the problem is with the BT shunt or with any kind of aortopulmonary shunt is that what is ideal today is going to be bad in a week or two's time. Because as the patient grows, the dynamics that you have in terms of cardiac output demand and so on and so forth change. So that's something we're left with as a problem. And there's no way around it. In talking of the single ventricle, whether it's a BT shunt or a conduit, is really an issue that has not been given a clear direction one way or the other. It depends on the surgical approach to that. So I think that really is a problem that we have, and I know that the surgeons that I've worked with, Dr. Frank Hanley and Marn Reddy, have always tried to get away from the shunt at their earliest possible convenience. I mean, we hope for single ventricle physiology to get to a bidirectional Glenn as soon as possible. The other thing about the Glenn that I think one has to realize, and Meryl has made this point, is that when you put a BT shunt in, or any shunt, you actually are stressing the ventricle, okay? And the minute you get to a BT shunt, the pulmonary, the demand is off that ventricle in the sense of its volume load. So I know that it's a prayer to get to the Glenn, and that again is a problem, because if you go too early, then you have problems with the venous pressure, and we've had to take down some of those who 3 months is sort of the borderline where we feel that we've been capable for doing Glens in the past.
Sure. We have more questions. One of them is talking about if there's any echocardiography a feature to predict if when we have tricuspid atresia, TGA, and restrictive VSD, and we have to band this patient, how can we predict the subaortic stenosis that this can happen?
Don't bend this patient, please.
That's my surgeon talking. I agree. I listen.
I don't know the answer, but don't bend this patient.
Because
you're very much at risk for developing sub-AS in that. It's a huge setup for sub-AS in that setting. And the only situation I could see that you could band in that situation is if the VSD is very large and the aorta is, normal size. And so you can look at aortic valve Z-scores. You could look at the VSD and, again, look at the rims of it and the size of it. Because if you diminish pulmonary blood flow in that situation, the VSD, the ventricle gets smaller, the VSD gets smaller. And so then you're in in addition, if that patient ultimately needs a DKS, you are potentially causing dysfunction of the pulmonary valve if you don't place the band perfectly well, because you can get pulmonary regurgitation, and then you could wind up with a patient with a distorted pulmonary valve, and then when you try to do the DKS, you wind up with semilunar valve regurgitation later. So it's a bit risky, and the only scenario I could see doing that in is if the VSD is very large and the aorta is of normal size.
True. Another question about echo features. How can you define that the ASD is restrictive on a single ventricle physiology?
I think there are a number of ways. One is the actual size of the defect. You can measure a transatrial gradient. We use the mean gradients for that, not peak gradients. So mean gradients across the atrial septum, upwards of over 5 to 10 millimeters of mercury is an indication of restriction for sure. I also tend to look at if the atrium on the restrictive side is distended, and if that's, for example, an HLHS, to look if the pulmonary veins look distended. So that's telling me that they're tense and under high pressure. And, you know, because there are some scenarios where maybe the pressure gradient across may not be that high if the ventricle is sick. But those are some of the ways that you can tell. And then there can just be anatomic suggestions like the deviated septum primum, because those will almost always become restrictive over time. So generally, we use the mean pressure gradient and the size of the defect in that scenario to help us know if it's going to become restrictive over time. One other thing is if you have an LSVC to coronary sinus in the setting of HLHS, for example, there's just so much room in that small left atrium. And those patients also can develop atrial septal restriction. And the surgeon may actually have to cut out onto the coronary sinus to open that area up when they're doing the atrial septectomy procedure.
Great, thank you. And this question I want to make to all of the three of you. So when we have pulmonary atresia, intact ventricular septum, and we try the perforation of the pulmonary valve on the cath lab, do you usually wait to see how the RV is going to behave, or do you stent the PDA right away? This is another question from Yahya, my fellow.
Your fellow's asking very tough questions, which is good.
This is very good. They are good. They are very good, the group. We are very proud of them, really.
Sorry.
In
Norman, do you want to start?
Well, I'm happy to. We've all experienced this problem. I don't think, as far as, look, you do this perforation, and you have to give the patient a little while to try and accommodate to the procedure. The ventricle is thick, it's diastolic dysfunction. It's going to have trouble, and I think the early closure of this, of taking the ductus out or stopping prostaglandin, whichever way you go about it, can be problematic. And I think if the problem is, of course, if you wait too long, then with the pulmonary insufficiency that develops because you perforated the valve, you set up the circular shunt, and it's never going to go away. Right. I mean, I think what you have to do is you have to, in the post-operative period, start looking at ways of keeping the pulmonary arterial pressure very low, including the use of nitric oxide. But I think I favor this, sort of intermediate, and don't ask me to define early, intermediate, and late, but intermediate use of getting ductus flow decreased by either going in and closing the duct, or by stopping prostaglandin, and giving indomethacin, in fact, even as a way of doing it. And of course, when I say that, of course, we're talking about keeping it under 10 days after surgery if you can get these kids in the early period of time. Late ductus that's open, I think, for a long time, the indomethacin or the whatever agent you use will not work. So
then you might have to coil the shunt, coil the PDA.
Yeah, you may have to coil the shunt, right?
Or coil the stent, yeah.
Coil or even device it.
Device, right. Yeah, yes. It's tricky business. I totally agree with Norman. I think in most cases we do try to leave pulmonary blood flow through one of those sources, either through leaving Prostin on, or if we're really worried about it, putting a more permanent source with a PDA stent, and then hoping that things will open up and the patient will be able to go on without developing the circular shunt that we all worry about.
Yeah. Sasha?
Yes, no, in our unit, the cardiologists love the strategy to do perforation, then 2 weeks with prostaglandin, like retraining the right ventricle. But the day you decide to close the PDA is the day that you need to do a shunt, most of the time. Right. And because sometimes it depends. It depends on the anatomy, of course.
Sure.
But I agree with what is fantastic of this discussion, that all the world have the same problem. Of course, there is.
Absolutely, we all have the same problem.
Please make the sense of this type of.
So everyone should just take comfort in knowing we all have the same issues. Nobody's.
And I just make another analogy. I mean, this is exactly the same as you have in Epstein's malformation,
Yes.
where you have a circular
That's
shunt.
right.
And I think that if you look at that as a paradigm for what happens here, and the work of Lisa Hornberger and Ian Adatia about this is that, you know, lowering the pulmonary arterial pressure even by with hyperoxia and with nitric oxide gets the patients in a much better situation. So I think that that's a perfectly analogous situation, with the exception of what happens at ventricular level, because the Epstein's valve muscle is really quite flaccid and is not generally hypertrophied. The problem in the pulmonary atresia is that what you're dealing with is a thickened, dysfunctional muscle, which has stressed itself by contracting against impossible odds. And of course, if there's a lot of tricuspid regurgitation, it can at least develop a volume. But the very small ventricle, you have to give it some time to grow.
Yeah, absolutely.
Probably one of the mistake is that we consider the patient for 10 days after he is birth, but he stay for 9 months during fetal life or 3 months with the pulmonary valve closed. So you ask to a right ventricle in 10 days to do
exactly
what we didn't do for 9 months. This is probably, I really appreciate what you say, because the prenatal diagnosis, the roadmap that you told us about the single ventricle, I think that is the real strategy for this patient, rather than only one shunt or something like this.
And by the way, these patients, even if you have success of two ventricle repair, they're never normal, right?
Yes.
Their RV is never normal. Their RV compliance is never normal. And many will continue to have right to left atrial shunting, and ultimately you may have to close that shunt on them. And they often will have, they may have RA hypertension in the long term. So, I mean, it's not a, you know, once you get to that stage that everything's okay. It's often not, because it started out small, and, you know, that's, as you said, it's been that way for 9 months, and it's not going to change so quickly. And even when it changes, it doesn't change to normal, ever.
Yes.
I have 3 more echocardiographic questions, and we are going to do this very quick, but I really want to be that you guys are able to answer them. First, Yolanda is asking how to measure the tricuspid valve size on pulmonary atresia and ventricular septum. And what do you consider that this tricuspid valve is not enough?
There are various views that you can measure it in. We tend to measure it most commonly in the apical 4-chamber view and the parasternal long axis view. The reason why I brought it up is because often the annulus itself is larger than the inflow, because the right ventricle is often so muscle bound that the leaflets don't have the opportunity to open very large. So I do think the annulus itself is quite important rather than the secondary orifice, because if you're able to open the RV outflow tract, then the hypertrophy can regress and hopefully the inflow becomes wider. And there are a number of studies which look at a variety of tricuspid valve measures. We generally do it by Z-score. I think Norman, correct me if I'm wrong, but I think the magic number seems to be a Z-score of -3.
Minus 2.5 to 3, yeah. That's
2.5 to 3, right, is like sort of the cutoff. So if you have a Z-score greater than -2.5, most of those patients can go on to successful two-ventricle repair. You know, again, what we consider successful. And then if it's less than that, we tend to go down the single ventricle strategy. Now, the coronary cameral fistulae come into play here. because if you have coronary fistulae of significance, particularly if they're RV dependent, then you don't want to decompress that ventricle under any circumstances, because that patient will have a demise because there'll be a coronary perfusion abnormality. So that's an important component in addition to the tricuspid valve size.
So yeah, I agree with everything you've said. The issue, of course, I've been influenced by Frank Hanley, who wrote the paper on Z-scores. And the reason why the Z-score of the tricuspid valve was brought up, because it's the only measurement that people can make objectively. Mm-hmm. And the calculation of the volume of the right ventricle is very, very poor. It's not impossible to do. It can be done. And of course, if you have less than a certain size, maybe 20 millimeters per meter squared of body surface area, you cannot survive with that ventricle alone. So that was certainly the case in a meta-analysis that the late Julian Hoffman put out for left ventricular size. And again is another long lecture, so I don't want to give it. But the point at issue is you can do the same measurements on the right side. And when you do this, as I've done many times, you'll find that the volume of the ventricle, in addition to the tricuspid Z-scores, puts you in a volume of much less than 20 millimeters per meter squared. And there's, of course, you've got the additional shunts that you can do on the right side and so on and so forth. But you cannot simply just perforate a valve and think that you're okay if you don't have a reasonable volume. And it's not impossible to do volumes. Biplane subcostal areas or 3D volumes will give you some kind of idea of what you can do. And 20 millimeters per meter squared, milliliters per meter squared of body surface area is the minimum. Because if you look at our volume as the stroke volume per meter squared, it's in the region of 60 to 70 as we're sitting down here now talking about this. Mm-hmm. So you do have to have a sort of reasonable ventricle before you can do it. And there are quantitative measures that can be made that will help you decide what is appropriate for a particular surgical procedure.
Well, I have only one question about a few cases that we follow as a pulmonary atresia that was treated as a neonate. Now they are 35 years, and they did 1 ventricle and a half repair. And at the same time, now the pressure, it's amazing, in the right ventricle, in the left atrium, in the right atrium, in the glen, is the same. So it's a Fontan.
Basically a Fontan, right?
Yeah, he's a Fontan patient with a lot of arrhythmia because the right atrium became very big. So I think, Norma, you have to tell more about this point, and Meryl also, because this is only opportunity to, because open a ventricle is something that we consider very challenging, but we have to think how this ventricle will work in the future.
Yeah.
This is probably the challenge. Sorry. Eh?
No.
No, and then it's like, I mean, being in a casino,
Yeah.
because you roll the dice, and you know what you don't have is the ability to understand how the dice are going to come down, and that's unfortunately the reason why we are not perfect at anything we do, because we don't have all of the prescience. The ability to foresee the future in what we do. We have to do what seems to be the most expedient and the best thing for the patients. Okay. So I've got a patient with pulmonary atresia who she's now married and had children that only got a pulmonary valvotomy, a surgical valvotomy by Frank Hanley when he first joined our practice in 1991. That was when she was a neonate. And she's just doing fantastically. So, you know, there you go. There's got the best on the one side and the worst on the other side.
No, but you are right. But so the message, we have to learn from this case, not from the neonate.
Right.
We have to look back to this case and which type of case arrived to have a normal life. This is the way.
I remember this case because we sent the patient to surgery without a catheterization. And I wrote a paper about this, in fact. And Dr. Robert Frieden, one of the outstanding experts on pulmonary atresia, wrote a reply, an editorial, and the end of his editorial was, how can something this small cause so much grief? And I think that that is exactly what you can say today about the pulmonary atresia group of patients. It causes a lot of grief, and we just are not great at making good results in this group of patients.
Great. Are you happy with this?
It's amazing. It's been 40 minutes of discussion. This is really impressive. Really impressive. I just have to thank both of you and Sasha, of course, to this amazing discussion. And I'm sure everybody learned a lot. And we have very sweet comments on the chat box. And I got maybe a dozen of WhatsApp already of people being very happy with this meeting. I hope we can do more of this. On the end of the month, we have another one with Dr. Meryl, and we are going to have Dr. Silverman as well joining us, I hope. And he joined us with Dr. Anderson's talk, and he has his own talks as well. So we are blessed. We are blessed to have you with us. Anything else?
Thank you very much.
No,
I'm very
it was a
happy to be
pleasure.
part of